Well, welcome everybody to Optometric Education Consultants National Webinar Series, Tuesday night edition. Tonight, our speaker is Dr. Jaci Theis, practicing optometrist, clinical researcher, international lecturer, and author. She received her doctoral and postdoctoral residency training in neuro-ophthalmology and binocular vision disorders from University of Cal Berkeley School of Optometry. She's a previous assistant clinical professor and founder and chief of the UC Berkeley Sports Vision and Concussion Clinic. She currently serves as assistant professor for the Uniform Services University School of Medicine, Department of Physical Medicine and Rehabilitation. She serves as a member of the Intrepid Eye Society, the American Optometric Association Evidence-Based Optometry and Vision Rehab Committees, and is a fellow of the American Academy of Optometry and National Academies of Practice. She's been awarded the Young Optometrist of the Year award in both California and Virginia in 2019 and 2022, respectively, and is UC Berkeley's 40 Under 40 in 2023, and Women in Optometry The Award Innovations in 2024. So we're going to have a very interesting topic, a topic that is of great interest to me in neuro-ophthalmic disease. I am certainly looking forward to it. I'm looking forward to the expertise that Dr. Jaci Theis is going to share with us. So please, everybody, a nice virtual warm OEC welcome to Dr. Jaci Theis. Jaci, take it away, please.
Thank you. And thank you guys so much for inviting me. I have been excited and slightly nervous to give this lecture in front of two greats. So thank you guys for having me. My financial disclosures are listed here, and none of them have any relevance to the topics tonight. So as we mentioned, we're going to talk about everyone's favorite thing, which is neuro-ophthalmologic urgencies and emergencies. And I'm really big about the reason I think people don't like double vision and cases that are urgent is they never look the same. And so when I give a lecture, I love to go over anatomy, and I really like to go over kind of how we can do a rote process of thinking so that you can troubleshoot these and make sure that you flag the right red flags. In the meantime, though, while we're going through kind of that process, we're also going to go over the epidemiology, systemic and ocular manifestations, particularly of these diseases. And the beautiful thing about optometry is we don't have that many emergent things. But the ones that we do have are giant cell, Horner's, intracranial aneurysms, myasthenia gravis, and intracranial space-occupying lesions. So these are the 5 things you really don't want to miss. And I always like to start my lectures about neuro-ophthalmologic emergencies with this quote, because I think it's something that is important to remember, that these emergencies constitute vision or life-threatening conditions if the diagnosis and treatment isn't promptly taken. So time is of the essence in a true emergency. But even if you were perfect and you did the right steps and you were immediate with it, these clinical entities often carry a very high rate of morbidity. And I think that's important for you to know, because you could be perfect and the patient might still die, or they might still go blind. And that, I think, is the hardest part, because usually for optometry, we have a high cure rate. They come in with blurry vision, I diagnose myopia, I cured them and they're out the door. And these conditions aren't like that. So do know that the best way to prepare for these is to just be prepared and to know what you want to do if it happens. And then if it happens, you know, as long as you do your best and you are as rapid as possible, then that's great. And unfortunately, sometimes the outcomes aren't always the best, as I'm sure Joe can attest to sometimes when these happen in your clinic.
Can't save them all.
No, even when you try. So the symptoms are big. So for me, what would be a symptom of a neuro-ophthalmologic emergency? So it's vision loss, double vision, eye pain, headaches, and positional dizziness. Those are going to be the things that you should kind of, when they're on your chart note chief complaint, have a small, I always call it a yellow flag that you need to dig for red flags. Now, I work in a multidisciplinary brain injury clinic, so I get the luxury of hearing what other people have for red flags. And so this is a red flag that's used in a lot of other disciplines. It's called SNOOP. So you want to look for other systemic symptoms, which we're going to dive really into the details too, based on how I like to dive into my RO, my kind of review of systems. But you want to look for systemic symptoms, particularly fever, weight loss. You want to ask if someone is pregnant, because pregnancy can also cause a lot of other emergencies. Neurologic symptoms. So all of a sudden, if someone's clumsy, obviously visual problems, we're going to find out. Trouble with speech, weakness, confusion, headache onset. So the big thing is some people are always headachy. And so you want to know, is this new, a different pattern of headache? And then if they're having a headache, how do they describe it? And does it get worse with certain positions, which could be totally benign, or it could be something very ominous. Are they progressive? How old are they? And it's funny because in this Snoop, they say if they're, after the age of 40, you want to get worried about some emergent conditions. But you'll find in a lot of the neuro-ophthalmologic emergencies, a lot of those happen between 30 to 50 years old. And then, like I said earlier, a pattern change. So pattern changes and headaches are always something that you want to be wary of. So let's pretend that it is, Wednesday morning, so tomorrow, and you go in and this is your first patient. So she's 47 years old. She has vertical double vision and right gaze, and it's pretty obvious why, right? When she looks to the right, she's got a very obvious vertical strabismus. So the first thing that you have to ask is, how comfortable are you right now? In this moment, this is your patient. And I would say that a majority of people feel a little uncomfortable and scared. And why does double vision scare us? And I think the problem is that what could cause this woman's problem could be something totally benign. Maybe she was born with it, or it could be life-threatening. Maybe this is a tumor. And this is, I have to tell her she has cancer. It could be something rare, like encephalitis, or something common, like a traumatic cranial nerve 4 palsy. So I think that's the problem, is that the differential diagnosis of double vision is vast. The other problem, and I think this is everyone's bigger fear of double vision, it's not a quick complaint. It always shows up at 4:30 on a Friday, and it's not a 20-minute complaint. When I worked with neuro-ophthalmology for a few years, one of the things I used to hear them complain about all the time, which made me feel more validated, was I hate when they stick a double vision patient in a 20 or 30-minute slot, because if the patient is a perfect responder, has the right answers, short answers to all of my questions, and I'm able to do my entire battery, I'd never finish in 30 minutes. And so that's the big thing for me, is to know that it's not a 20-minute complaint. If you really think that it's something emergent, and a complete neuro-ophthalmologic emergent workup will be about 45 minutes up to 60 or more. So just know that you can help yourself by telling your staff these things as well, because that was a big problem for other people. And then just recognize that it doesn't just scare us. So having worked in multiple settings, most ophthalmologists, not a big fan of double vision either. And then neurologists, not a huge fan, primary care physicians, ER physicians, nobody likes it. And I would actually say that optometry is probably better at diagnosing double vision than anyone else, especially ominous double vision, because ominous double vision is often little itty bitty deviations. And ophthalmology is really good at looking at the big ones, because the big ones are surgical. But the little ones, which are new and growing, those ones are often missed because they're not looking for small stuff. So it scares us all, but the best way to go about it is just be prepared for it. So we know the symptoms of neuro-ophthalmologic emergencies. What about some signs? So obviously the optic nerve, you're going to look at the optic nerve. We're looking for edema or pallor, intraocular or extraocular abnormalities, so things that would cause double vision, unequal pupils, and then eyelids. So these are the signs of various things that can present for neuro-ophthalmologic emergencies. And one of my favorite rules, it's short, it's sweet, it's simple, is this one. If you just have a pupil problem, or you just have an eyelid problem, or you just have an eye muscle problem, you're probably okay. If you have 2 or more of those problems, that's a red flag that they might have a neuro-ophthalmologic emergency. And you'll see when we go through all of the cases going forward that a lot of them are going to have a pupil and an eyelid problem, or an eyelid and an eye muscle problem, or all 3. And so that's a good pearl for concern when you're seeing these kinds of cases. Now, the big question people always say is, what's the difference between, a neuro-ophthalmologist and an ophthalmologist, or a neuro-optometrist and an optometrist? And the difference is a really intensive case history. So the difference is a very long exam. But in general, the reason is because if you do a really good history, you don't need as much of an exam. The exam is confirming what you think you already know. And so the big thing for me is double vision, and we can do it with vision loss as well. But I always want to know, and the key, by the way, is I have my front desk staff do this when patients call, because I don't want to be emergently working up dry eye. So I want to know, is the double vision one-eyed or 2? Is it worse when they look up, down, left, or right? And you will always get a snarky patient that's like, I don't know. In which case you say, look left, look right. Does it get worse? Sometimes people are scared, and their response to fear is being snarky in your chair. And so I just push right back when they do that. When it comes to vision loss, same thing. Are you losing vision in one eye or both? And is it one side of your field, left or right, up or down, quadrant? So similar kind of question workup. I want to know, when did it start? And when it started, was it all of a sudden, like I had double vision at 10 a.m. on a Tuesday? Or is it kind of come and go for the last few weeks? And what were you doing? A lot of times gaze dependent double vision, like double vision when I look down, patients will say, I get it when I'm reading. But the reason that they get it when they're reading is because they're in a progressive and you guys force them to look down in a progressive to read. And so that's the only time that they're actually looking down commonly. So do know asking what they were doing will be helpful. And then always doing your cover test in the gaze that they were having the problem. Is it getting better, worse, or staying the same? How long does it last when you get it, particularly with vision loss? Very important to know how long they're getting it. Is it worse at the beginning, end of the day? Does it get better if you cover an eye or if you blink? And then do they have a history of childhood strabismus or a previous eye surgery or vision therapy? Now, just because somebody had a strabismus as a child doesn't make them immune to having a neuro-ophthalmologic emergency as an adult. So I always say a dog can have both ticks and fleas. And so someone can have a developmental strabismus and then get an acquired one. So while I sometimes do feel a little bit at ease when that person's like, sometimes in college, I would have a few drinks and then I would get double. There's a small part of me that's like, oh yes, this might be a pre-existing problem, but I have to prove to myself it's a pre-existing problem. So then once I've figured out kind of what does their double vision look like or their vision loss look like, the next thing I need to know is, do they have any other symptoms that would make me think this is emergency? And that is what this master list is for. So if there's ever a slide that you should take a picture of, it's this one, because it took me a very long time to come up with. So what I did is I read through every article you could find on the neuro-ophthalmologic emergencies we're going to talk about, and I essentially created this list. And so the reason that I find it's important, as you can tell, now I'm not as young, but I've always been very young looking. And when I tell someone, hey, I think you need to go to the ER, I had a lot of problems early on in my career where people were like, but I got a meeting at 2, so maybe I'll go later. Or you have the other person where I'm like, I don't think you need to go to the ER. And they're like, oh, I need to see someone else who's like older with white, like gray hair. And then I'll trust them. And so I found that this helped me with that. It also helped me with decision making quickly, because the hard part is knowing when do I want to pull the trigger on imaging and not. So this is how I do it. I worked in a hospital system and you don't want people to take all day. But the other thing that's important is you need to have these documented as no's in your chart, because things can evolve. I've had patients come to see me, they have no symptoms of a stroke, and then 2 hours later they have a stroke. And they've gone a chart review through my charts and noted, yeah, there's no way they were having a stroke because I went through and pertinently documented these no's. So this is how I kind of deliver it. Mrs. Smith, I know you've had double vision and you might have Googled it, and there's a lot of things that can cause it. So I'm going to ask you some yes or no questions. I only want you to say yes or no. We'll come back to it and elaborate on it. That'll help you get through this list much faster. So then I always want to say, since your double vision or your pain, blurred vision started, have you had any of the following? Pain in the eyes, face, or neck? Any changes in vision if they've had double? Headaches, tingling in the limbs, fingers, or toes, numbness or weakness in the face, arms, or legs, any nausea or vomiting, changes in balance or vertigo or dizziness, any light sensitivity or hearing loss. Particularly, you're looking for unilateral hearing loss or recent onset hearing loss. Have they had any ringing in their ears, jaw pain when they chew, neck stiffness, pain on the sides of the face, so the temporal artery, any trouble with swallowing or breathing, any recent weight loss or weight gain that was unexpected? And a lot of people right now are on weight loss medication, so I always have to say the unexpected part. Have you recently had a fever, any history of trauma or head trauma or chest trauma even? So any type of motor vehicle accident I want to know about. Any history of systemic disease. Now I'm looking specifically usually for vasculopathies, heart disease, cancer, MS, thyroid, autoimmune diseases. The big one here on this slide is medications. You have no idea how many people will write on their metformin, but they're not taking their metformin, or they were prescribed it and they're not taking it. So when I go over medications, the first thing I say is every single medication that you're taking on this list, including topicals, over the counter, and are any of them new? There's a lot of people where they just started some new antidepressant or antipsychotic medication, and that's when their double vision started or their blurred vision started. Or is there a medication that you were taking that you stopped taking before you saw me that is not on this list? And there's a lot of people that I've had where, oh yeah, 3 weeks ago when my double vision started is when I decided to stop taking my metformin or my cholesterol meds. And it's a very quick find of what caused it. Have they recently been traveling? And then any trouble finding their words or speaking. So it takes me about 2 to 3 minutes to go through this list, and I just go yes, no, yes, no, yes, no, yes, no. But I love this because if I'm going through and they have new onset double vision and I'm like, no, 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 by the time I get to the bottom, I'm not as worried that this is an emergency. So when I have to tell them, I think we could watch this one, or whatever ends up being kind of my prognosis for them, or where we're going with the case, they feel good about it because they also, especially if they're a nervous person, they're feeling better because they said no 1,000 times out loud. Other end of the spectrum. Now, let's say you had a person who said yes to a couple of these things. Now at the end, when you're like, I think you need to go to the ER right now, they're on board because they understand from the questions you ask that there's something else going on. So I have found this to be a really helpful list. And then the other big thing, and I mentioned it briefly before, but you've got to teach your staff how to triage double vision and know when to put monocular versus binocular diplopia in your clinic. So I will always say one of the proudest moments I've ever had is when my front desk person texted me while I was away at a conference. And the text said, "Hey doc, just so you know, someone called, they had new onset double vision. I went through that list that you gave. And so this is what she said." So the person, do you see double with both eyes open? Yes. They said, no. Okay. Cover one eye. Do you still see double? They say, yes, it's monocular. No. Okay. Do you still see double if you cover the other eye? They say, yes, it's monocular. And she said, no. So she said, I went through your list. She had binocular double vision, which flagged me to go through your other list of yes, no, yes, no, yes, no. And it sounded to me like she was having a stroke. So I sent her to the ER. She did this all on her own without me going. And maybe 24, 48 hours later, the patient had sent an email to our practice. We'd never seen this person before. I've never seen this patient. And just said, thank you so much. You saved my life. I had a stroke. And so teaching your staff how to triage is huge. Also, because a lot of patients will say they have binocular double vision, but they have bilateral monocular diplopia from dry eye. So it's also a nice way to make sure you're not urgently getting in the wrong case. But the key for me is always making sure you have the right person in your chair. The other reason it's important is you don't want to spend a ton of time doing a neuro workup. And I've seen it. I've had referrals where people have done this ridiculous neuro workup on someone and they just have dry eye or uncorrected astigmatism or keratoconus. And it's bilateral. So they definitely have, if I cover, it gets better, but it's still there because it's bilateral monocular diplopia. And monocular diplopia is going to be your typical eye exam, whereas binocular diplopia is going to be usually some type of orbital, neurologic, or kind of muscular issue that's going to take a much bigger exam. And then this is the other stuff you have to add. So it's not a short exam, right? So the only thing you will maybe save time on is not refracting, because if you do pinhole acuity and you pinhole and you can prove to yourself they can get to 20/20, you can save some time on refracting. But then you're going to look at color vision, pupils, visual fields, measuring the eyelids. We'll go over that today. Orbits, looking a good look at the optic nerve and fundus. And then you want to screen the rest of the cranial nerves if they have a cranial nerve palsy. So it's not a quick exam. I will say one of my favorite tests that's on here that people forget about is the red cap DSAT. I don't know about you, Joe, but this is my favorite color test for a new onset optic nerve problem. The number of times I've seen people that do the Ishihara, and I'm like, by the time that person has an Ishihara color vision defect in one eye or the other, their vision is way down. Versus my 20/20 newer onset, I have reduced acuity because of an optic nerve problem. I find the red cap is actually probably more sensitive. Occasionally the AOHRR. What do you think on that one?
I like the red cap as well, and it can very quickly rule out something that there is actually something that's real. When they say, no, it's about the same. Okay, that's good.
Yeah, yeah. So now the annoying part is when they fail it, but you know that they actually are fine. So there's some danger when you do that one. But it's just fast. I think people forget about it and then they just don't check color at all. So.
Hey, Jackie, I got a question for you. When you do your red cap, is it worthwhile to check quadrants and central, or are you just going central?
I think it depends on the person's complaint. For double vision, I'm just doing central, unless they complain that I have vision loss in one area or another. Or because then you're looking at more often than you're looking more at contrast loss in a quadrant. I don't know. What about you guys?
I agree.
Yeah, I was just, some people I hear out there lecturing, they're saying you got to check all the quadrants in central. To me, I found it in neuro, and again, in the double vision case, I just want to do real quick. How's this eye? How's that eye? You can do it to look for potential visual field defects, but to me, it's a quick and dirty in double vision, quick way to assess the optic nerve or status. So.
I think it's helpful. I mean, I've only really done it if it's post-stroke, the person's already had a hemianopsia and they're complaining of, I feel like something's off with this eye or that eye. And then I'll do it more to show them of like, hey, look, when it's over on this field, even though it's usually when someone got their vision back. So it's like I had a hemi and then it came back or it partially came back. But the thing is, a lot of times they still have vision loss in that area. And so it's more of a relative scotoma. So it's like they can see, but not really. And then I find it's helpful more to just explain to them why they feel off. But I would say in a diagnostic setting, personally, I think visual fields, those quadrants are better. That's just my opinion. So
Perfect,
let's go
thanks.
back to that case. And then I know we'll jump into a poll, but let's go back to that woman. So now we've kind of thought a little bit about her double vision, so a little bit more. So it started for her a few weeks ago, right after she was in a motor vehicle accident. She did have loss of consciousness. She did have head trauma on the steering wheel and the headrest. So she hit her head forward and she hit her head back. So that being said, we will launch into our first poll.
You know,
Let's get it.
Go ahead, while
Joe.
we're doing
It's
that,
open.
a question just came in, and the question is, how do you rule out false positives with the red cap test?
I usually just tell, well, I guess it depends on how you want to do your, I mean, ruling out false positives, I think they're wrong. I then just do the AOHRR.
Kind
Go
of
ahead.
the way that I look at it would be the absence of any confirmatory findings. A person may not really understand it, or they may have a media difference between the right and left, and they may perceive that. But at the end, when I'm getting close to the end, if there isn't anything else supporting an optic nerve issue, that's kind of really how I rule out the false positives. There's no support. The OCT is fine. The visual field is fine. The optic nerve fundoscopic examination is fine.
I also will check contrast. So when people have immediate opacity, I often find that the color desat is true because one cataract's a little bit worse than the other. And so what they're picking up on is the contrast defect, not the color desaturation. And so if, it's one thing if they say lighter, but if they're like, this one's orange and that one's red, and you're like, that's not the right answer. And that's kind of how I've kind of looked at them. So,
All right, you ready for your replies?
yes.
Cranial nerve 2 is 25%. Cranial nerve 3 is 11. 4 is 43%. And 6 is 21%. So your winner is 4, and then it's changing. Whoop, it just went to 2. We went to 2, cranial nerve 2, now cranial nerve 4. Now it's back to cranial 4. So 4 and 2, and then 3 and 6.
Yeah. So it's a little bit of a trick question. There is actually no confirmatory study as to which one, but I would say optic nerve. Obviously, we know with increased intracranial pressure, optic nerve, we're going to see papilledema. But oftentimes abducens. The abducens are also. So I've had a lot of cases of patients with increased intracranial pressure that have a 6. So 6 nerve palsies in general can be very ominous. So that's another one. If you're worried about increased intracranial pressure, to do is cover test in your lateral gazes as well and make sure they don't have a 6. So just as a review for people out there in our adult population, when people have different ocular motor cranial nerve palsies, we know that the most common cause of somebody having a cranial nerve 3 usually is going to be ischemia, but then closely followed by stroke, aneurysm, and trauma. For a 4th, usually congenital, although one could argue they had trauma on the way out, and that might be why they had it congenitally. But trauma followed then by microvascular issues, stroke, and then demyelination. The ones in italics are, it could happen really to anyone. And then for abducens palsy is actually, if you're going to get a tumors often cause increased intracranial pressure, and that is one of the reasons that abducens palsies need to get worked up more, as they're more likely to be caused by a tumor than anyone else. Also can be caused by trauma and microvascular conditions, stroke, and demyelinating conditions. So in the end, you're going to do, I kind of wrote the workup for all of them, but the workup in general is pretty same. We'll go over some of the lab testing for these cases because some labs are a little bit different, but for the most part, you're going to be doing an MRI of the brain and orbits, an MRA if you're worried about any type of aneurysm or neck problem, and then some lab work for systemic diseases. So for this patient, we know she's got vertical double vision, and it's worse when she looks in one gaze. So the one that we're worried about with this patient is going to be a 4th nerve palsy. So let's talk about traumatic fourth nerves. So we know that it has the longest course from the CNS to the target muscle, and you're more prone to have a cranial nerve 4 palsy than a third and a 6, especially when the mechanism is I hit my head forward and then I slam my head back. So I see a lot of fourths and bilateral fourths in my clinic, and it's because they slam their head on the back of the headrest. So they got compression directly on those nerves right where they crisscross. Oftentimes it's vertical double vision, worse in down gaze, plus or minus torsion. The prognosis is better for a smaller magnitude and the less torsion they have. So when you look at statistics, about 50% of them will resolve, usually within about 3 to 6 months, but it might take up to 12 months. A lot of surgeons won't operate on them for more than, if they're fresher than 12 months. So these patients can get surgery, and I can't say that enough because I've had little pediatric patients where someone diagnosed the fourth and they're like, don't worry about it, just don't look to the right. And it's like, you're going to look to the right at some point in your life if you want to drive a car. I work with strabismus surgeons all the time. They don't like to do a traumatic palsy usually within a year because it can definitely cause double vision, or it can get better and they don't want to overcorrect it, but they can definitely work, especially on the torsion. So that can be helpful if you just can't get them to fuse. So I find that helpful. Also, those surgeries are 20 to 30 minutes. So it's a very quick fix for these patients. But in the meantime, I oftentimes have to fix them with a little bit of Fresnel. So if we look at traumatic strabismus in general, the majority of them usually come from a motor vehicle accident. So you're not going to commonly see a cranial nerve 4 palsy in a mild concussion or a mild traumatic brain injury, but a motor vehicle accident at a high speed, you're more likely to have a traumatic cranial nerve palsy. You can also get it with falls, fist injuries, blunt traumas. So when should I image? I think this is always the big question when you see a palsy. So obviously if they have more than one palsy, if they're young, if they have no vasculopathic risk factors, absence of improvement in 3 months for the isolated palsy, and then if it's funny looking, is kind of the rules of when to image. So I always remind people, what are the other cranial nerves? Oftentimes with other cranial nerves, people just think 3, 4, 6. There's more than that. So you have to do more than your cover test. So with our eye exam and our cover test, you're going to get 2, 3, 4, and 6. But I love to go over the other ones for everyone. So we want to start with the olfactory nerve. So the way that you do it essentially is you just have the patient close their eyes. You bring an odor from one side, have them close a nostril and tell you if they can smell it or not. The odor you want to use needs to be something sweet smelling, like vanilla, coffee, or chocolate. You don't want to use anything pungent because if it's pungent, it will actually, like smelling salts, it'll trigger the trigeminal nerve, in which case you're going to get a false positive on your olfactory testing. So you don't want to use smelling salts for this test. And then you want to check both sides and make sure they can smell equally on both sides. It is not uncommon for people with concussion and brain injuries to have smell loss, particularly if they have frontal face trauma. The next thing you want to do is your trigeminal nerve. Now, obviously, we know about corneal sensitivity testing, and you want to also test the other distributions of the trigeminal nerve. So you'll have them close their eyes. I usually just use a Q-tip and have them tell me when they can feel it. And the side that I'm concerned about, I'm going to have them just yay or nay. Does it feel equal to the other side? Because sometimes they'll say I can feel it, but I just don't feel it as much as I feel it on the other side. And you want to do the first, second, and third distributions. Now, the trigeminal nerve also has a motor component, so it also innervates the mandible. And so you're going to have them bite down as hard as they can and see if they have equal pressure on both sides. You can also have them push against your hand and see that they have equal strength on both sides. You want to have them open their mouth, make sure it doesn't open like that, over to the side. And then cranial nerve 6, you'll already screen with your cover test. Then you want to check the facial nerve. So the facial nerve, this is also helpful for some of the other conditions we'll see down the road, but you have them raise their eyebrows, make sure that they raise equally. And then what you want to do is have them close their eyes as hard as they can, and then you're going to try and open their eyes while they're doing that. So you're essentially testing the orbicularis oculi. Optometrists are literally the best providers to test cranial nerve 7 because we know how strong people are when you're trying to put an eye drop in. So when you're having someone try to hold that eye as hard as they can and the thing just pops open, that is a sign of orbicularis oculi weakness, and you can test both sides. Then you're going to have them smile and make sure that they can smile equally and one side doesn't frown, and then just have them frown and make sure that both sides can pull down. So you're testing the buccinators. Then you want to test the acoustic nerve. Now, I know technically in the textbook, you have to get one of those tines and you have to ding it, and there's a whole process. If you own one of those things, you can't find it when you have an emergency, guaranteed. You'll find it once the emergency is already at the ER. And if, for me, I've never been in an office where they've had one. But these are the tips that I've learned when I've worked in the ER. So if you have a ticking time watch, you can use a ticking time watch. I never have. So what I use are just my fingers. And so what I have the patient do is close their eyes, and then I just move my fingers and say, tell me when you can hear me with rubbing my fingers together. And so you'll get kind of one side and then you come from the other side. Again, I'm not an audiologist. I don't need to know their full frequency, but I just need to make sure that one ear is not here while the other ear is way over on the other side. So it's a way to just look at how symmetric is the hearing for that patient. Then you want to check the glossopharyngeal nerve and the vagus nerve. So you have them say ah and make sure that both sides of their mouth raise equally. You can technically put a, tongue depressor in there and see if they gag, or you can ask them if they can swallow their food easily without regurgitating it. Also easy to do. The accessory nerve is going to innervate their shoulders. So you're going to ask them to shrug their shoulders up and make sure that they're not asymmetric. And then the hypoglossal nerve is going to check their tongue and then make sure it doesn't pop out to the side. You can also check the strength. I recommend doing it through the cheeks so that they don't touch your hand with their tongue, which is kind of gross. So those are your cranial nerves. And so when somebody has a fourth nerve, you need to check the other ones to see if you need to image, in addition to the other kind of reasons we would image. So if we go back to our patient, her vertical double vision started a few weeks ago, right after she was in a motor vehicle accident. She had loss of consciousness, head trauma. She had a negative CT scan in the ER. So for me, when someone's had a head trauma, most of the time they're not going to do an MRI. I'm mostly worried about a subdural bleed. And so I'm going to check pupils and things like that. But if she's had a negative CT scan and everything else is not involved, I'm not too worried about doing further imaging unless there's something else that makes me concerned, candidly, because it makes sense. Her mechanism of injury makes sense. But let's pretend that I wanted to scan, or let's pretend that this case didn't have the luxury of having a history of something that caused it. If I don't know what caused it, she is young, she is 47. So this is usually what I'm going to send for lab work. If she's vasculopathic, like I have, I have diabetes and hypertension, and I think that's probably what's causing it, usually I will still order lab work, but what I'll tell patients is I'm going to order lab work. If all of your labs come back normal, we can talk about getting neuroimaging. I'll do that a lot. But do know that if you want to order contrast dye, they do need to have a calculated GFR within the last 6 months. So when I order my lab work for my isolated cranial nerve palsies, I put in a calculated GFR so that if down the road I do want an MRI, I've already done that lab test, so I know that I can order contrast if I want. And then again, you can do the whole battery if you want, or you can use your case history to decide what battery you want to do.
All right, we always get yelled at for using acronyms, so you have to tell us calculated GFR.
Glomerular filtration rate. So essentially what they're trying to check is see if your kidneys can handle the contrast dye and excrete from the contrast dye. And that's why you want to calculate a GFR.
Then I have a question for you. It's just, I don't know the answer, and I never really thought of it this deep, but when they have, like in this case, a trauma, is it like damage, ischemia, compression, vibrations, whatever, from the nucleus to the nerve to the muscle, or is that whole trochlear kind of pulley thing where the trauma is?
I think it depends on the case.
Okay.
And so we know that with some trauma, you can have inflammation, and the inflammation can be damaging to the nerve. In some traumas, you do actually have a subdural hematoma, and no one did a CT scan to know it. So the blood compressed to the nerve. I'll give you kind of the next slide because that's the other great question I was actually going to just get into is it also depends on the nerve. So the fourth nerve is very vulnerable to trauma just because of how it travels within the skull. And so it's easy to get a compression on the nerve. Nerves are very delicate little tissues. The third nerve is very internal. And I've always had all my other ophthalmologists I've worked with have said third nerves are ominous only because their pathophysiology is so internal that something bad had to go awry versus, it's just on the outside and got smushed against the skull. So with a third nerve palsy, if you're getting a traumatic third nerve, you had to have, and I listed them here, when it comes to trauma, rootlet erosion, distal fascicular damage, stretching of the nerve, decreased blood supply because something happened internally to the blood supply, herniation or mass effect. So a lot of people, you have to have a lot of trauma on the brain to get a third nerve. But oftentimes, if you were to do an MRI on a fourth, you're not going to find anything. So that's the other reason why I didn't scan this case, is because out of the likelihood, based on her presentation and all the other signs, the likelihood I'd find something is low. If it was a third, I would have scanned it. And if it was a sixth, I would have scanned it too. But fourths, I'm a little bit more, only because I've done it enough to know that most of the time, I also have the patients come back. If anything's getting worse or their symptoms are worse or she had any positive symptoms, I would scan.
Yeah, Jackie, you're correct, and I think it behooves us to emphasize to the audience, it takes a lot of trauma to have a third or sixth. But you're right, fourth is relatively exposed. I had a very similar case. It was a 17-year-old who had an auto accident. I mean, this was the equivalent of bumper cars. I mean, there was no major trauma or anything. Next day, she had a massive fourth.
Yeah. And they're small, and you know, the other big thing I always say we don't think about for cranial nerves, but the facial nerve. I had a neurosurgeon the other day who was like, the face is just the crumple zone to the brain. And I was like, who are you? But when you think about it, and the reason we were talking about it is because I've had a lot of patients where the airbag doesn't go off. And so they come to me with eye pain after they've been in a motor vehicle accident. And when they slam their head against their forehead against the steering wheel, they get compression of the supratrochlear and supraorbital nerves. And so they're getting neuritic eye pain. And so the first step is just ice it. But also you can always send for a nerve block if it's persistent. But people forget that we have nerves that are just right on the surface. And if you crunch it or crush it, it's easy to get it. And with a trigeminal nerve, it's a pain nerve. So if you crunch that one, you're going to be in pain. With a fourth nerve, it's a innervating nerve. So that's why you're getting double. So the symptoms also will make sense. But the big thing with trauma is you can get multiple. So now, as mentioned here, third nerves, I don't see them in my mild TBIs. I see them a lot in my moderate TBIs, and not a lot in moderate, sorry, my severe. So we have an inpatient unit also. And the inpatient unit, I would say a lot of them end up having third nerves when I'm treating them. Now the beauty of the third nerve is it also has the levator. So it has what I call nature's patch. And so if the ptosis is big enough, they're not going to have double until the ptosis gets better, and then they'll have double. When it comes to the sixth nerve, because I know that the sixth nerve loves to be increased with increased intracranial pressure, and it is not uncommon for people to have increased intracranial pressure after trauma, I will image a six. And they do, you know, the studies are all over the place as far as spontaneous recovery, but no one will ever fault you for running an MRI on a cranial nerve palsy. Like, no one's ever going to be mad. And I actually had a neuro-ophthalmologist tell me that my hit rate was too high. Like, every time I sent for an MRI, it came back positive, and he was like, your hit rate needs to be lower. He said, you know, optometry, we're very conservative in our ordering of testing. Like, we want to be 100% right before we order an MRI. And ophthalmology is more conservative in their management, so they order them more often and get normals more often. And I think that's something that we could take from them. I don't feel like anyone ever told me. I always felt like I had to be 100% to order because I didn't want to over order. And I think in these cases, it's okay to over order.
You know, Jackie, just a bit of a similar but humorous story. I had a patient that I had a neuro image, get a brain scan. It came back negative, and the patient called and was complaining. He wanted me to reimburse him for the MRI. And
Yeah.
I said, well, hey, maybe next time we'll get lucky, it'll be a brain tumor. And I hung up.
Yeah. So part of that, I always, when I'm ordering a test, I always say, I'm ordering this test because it could be something really awful. And what we want is it to come back normal. And I think that way I avoid that call, because I do not want you calling me mad that it's normal. We want to be glad it's not a tumor. I've had the opposite, where someone had a brain injury or and we did just like a routine MRI on them, and they secretly had this massive tumor no one knew about. And it was only because she'd gotten in a car accident. It had nothing to do. It was like, we ended up saving her life. And that was totally by luck, because there was no reason for us to have found that tumor. So sometimes those things happen too. So.
Joe, what do you always say, since you do a lot of malpractice, and that kind of feeds off of what Jackie's saying here? You've never really had to defend a case that if they've imaged or did the right blood work or did a culture, cornea sensitive.
I've done probably 200 cases. I'm working on 4 cases right now as an expert witness. And I can't think of a single case where the optometrist being sued had done neuroimaging, cultures, or blood work.
Yeah. Now, I will say, having just had to bang my head against the wall to get an account with LabCorp, sometimes you really have to work for it. Like, they don't have optometry as a dropdown. So if you're trying to get lab work established, by the way, do it before you need it. I was just switching my EMR, so I had to switch to a different lab group. And they don't have optometry as a drop down. My poor front desk staff had to call them every other day in order to get affiliated with them, which is fine. But that's the big thing for me is you don't want to wait until you need it because it can take time to get those things set up. So if you want to help yourself with emergency, that's the biggest help for that. The other big pearl when you're ordering imaging, I don't know how much you've talked about this before, but if you put stat, you will get it within 24 hours. So if you're doing giant cell testing, put stat on the order and it will pop to the top. Because you don't want that to be shuttled to the end with all the other lab work. So putting stat on an order, the labs will take it very seriously. So also be cautious when you do it as well. All right, so we're going to move on to a different case and kind of different workup here. So now
Actually, Jackie, before
Go ahead.
you move on, there are a couple of questions I kind of want to keep up on them. One is was your wording for a red cap test? Now, when I'm doing it, I have them cover the suspect eye and look with a good eye, and I hold it front, ask what color is it, and I expect them to tell me red, and I say switch on over. You know, how red is it? Still the same color? Yes or no? And if it's no, you know, how much is it less? Like it's very, very subjective. Do you do anything different?
It's pretty similar. So I always have them use the kind of normal eye first and just say, I want you to look, obviously you can't do it for a bilateral case, but I want you to look at this red and I want you, is this cap red to you? Yes or no? It'll be yes, no matter what, even with a defect. And then they'll say, we'll say, if this were 100% red, switch to the other eye. Does the other eye also see the cap to be 100% red?
Mm-hmm.
And that's kind of how I use the same. And then if they say no, I would say a lot of times they say that it is. And then I want to know, because if they're like, it's like 95% red, I'm not worried about
Of
it.
course. Now, do you ever order an MRI with thin slices of the brainstem? I've seen peds OMD, this is a question, do this, but wasn't sure how often is recommended. Why don't you go ahead? I'll give you my thoughts.
My thoughts have been I'm not a radiologist. And so I find that it's better for me to tell the radiologist what I'm looking for and have them decide on my slices. And so it just also depends on your relationship with who you're ordering with. So, and knowing who your team is. So you do want to do your diligence of who you're sending people to. But I find if I'm saying I'm concerned about a cranial nerve 6 palsy and I would like you to do an MRI of the brain of the orbits looking for any lesion that could cause a cranial nerve 6 palsy, I usually find that they end up doing what I need. I've rarely had to go back in and be like, oh, if that slice was smaller.
Yeah,
That's my opinion.
the critical pearl to share with the audience, and I've always done this, is the world's best neuroradiologist cannot help you if you don't order the scan, order the right scan, and tell them what you're looking for.
Yeah.
That's
So-
really our responsibility.
And I think the big thing is for me has always been telling them what you're looking for.
Mhm.
Like it can't be double vision. And I've seen that a ton on scans when I read them and they're like, oh, patient come in for diplopia. Well, where do you want me to look? That poor radiologist has no idea. But I think, the more detail you know, the better. But if you don't let not knowing the detail not let you order the test, just tell them what you're looking for. And know that you're going to do a better job at figuring out which cranial nerve it is than the ER will. So optometries always end up being better at that.
So I'm going to make a comment and then I'm going to just make another comment is that I agree 100%. That's how I work with my MRI is I can usually narrow it down right side, left side, where we're looking, the cranial, they know the anatomy, cranial nerve 6, make a phone call. I think the biggest thing out of this that everyone said, make a phone call, talk to them, help them out, be a teammate, and you'll get the right test ordered. You'll get thick or thin, and they'll know what they're looking for. If they'll go back and recut if they need to, in a sense, and looking for something that along the 6th, 4th, or 3rd. And the other thing that I'm gonna make a comment on that is correct. They will push that stat up, but make sure you also read it stat. I see a lot of people are like, oh, yeah, I work Mondays and Wednesdays. So I ordered it stat on Monday and I came back and read it Wednesday. You probably should either read it Monday or Tuesday. So try and if you order something stat, read it stat.
Yeah. And if you are ordering it stat, it's because you think they might die from it. So you probably should see it, be looking for it. And you are responsible for it unless you have someone else be responsible for it. So if you are going out of town, find someone else to be responsible for it. That's always okay too.
Because what happens a lot of times in the GCA cases, people are like, well, I didn't really think it was. So I just ordered it just to cover my butt. And then I looked at it on, 2 days later. I'm like, it's probably not the best way of doing it.
The nice thing too now though is that patients will get it first too.
Yeah.
Right.
And I've had that a lot. And so I always tell patients too, I'm like, sometimes you get a flag before I get a flag. So if you get a flag, call my office and we will take a look faster if you feel that we're not calling you. Because I've had a lot of patients where they're like, and this is the worst, they're like, yeah, I got an MRI result on my e-chart and they still haven't called me and told me what it is, but I can read the report. And you're like, oh, you just diagnosed yourself with a tumor and no one told you anything. Like, so do know that and kind of set the tone for that, I think is important. So, all right. Any other questions out there?
No, you're good.
Okay, good, because this is one of my favorite cases. This is a 65-year-old Hispanic male. So he came in complaining of a left eyelid drooping and constant horizontal double vision at distance and near. He said it started a few weeks ago and now it's becoming worse. His history of present illness and ROS is completely normal, and his entering visual acuity is 20/20. So I want to ask you guys, he's got double vision and ptosis. Which one are you going to work up first?
If he's got double vision and ptosis, I'm going to be working them both up simultaneously.
Okay, but you have to choose if you're measuring the eyelid first or the cover test. Which one are you grabbing? I'm gonna make you.
I am probably doing my cover test first.
Okay. What about you, Greg?
Yeah, I'm gonna probably lean. I'm probably more scared on the way the eyes are aligning. I want to see where they are, and then go back to the eyelid. But
Okay. So for me, the differential diagnosis of ptosis is way smaller than the differential diagnosis of horizontal double vision.
Mhm.
So I actually will always do the ptosis first. And so for me, I'm going to look at if he's got a ptosis, it's either a muscle problem, an issue with the muscle tendon, which would be aponeurotic, a nerve problem, a mechanical problem, trauma, or a pseudotosis. And so just by knowing this guy's case history, I know he wasn't born with it because it started a few weeks ago. It's not CPEO. Chronic progressive external ophthalmoplegia does not start quickly. It is very slow growing. And by the time they get the ptosis, they've had many other things first. Aponeurotic, meaning that they have trouble essentially with the insertion of the muscle into the end of the eyelid, can happen with age. So that's still on my differential, but he's not an eye rubber and he doesn't use RGPs. He doesn't have Marcus Gunn. I'm sure he's had a juice box at this point in his life and he hasn't figured that one out yet. So, and then mechanical, I know he doesn't have anything in there. It is possible there's a tumor in there always. He has no history of trauma. And so very quickly, just by doing my differential, I've already ruled out a lot of things. And there's only a handful of things on here that can also cause double vision. So for your eyelid exam, what are you doing? First, obviously, you're going to measure the eyelids. You want to not just measure the palpebral aperture, though. You do want to measure MRD1 and MRD2. And then you want to look at how the levator functions, and we'll go over that. Fatigue test, ice test, Kogan's lid test, curtaining, enhanced ptosis, orbicularis oculi testing. There's actually a lot of eyelid measurement testings that you can do, and we're going to go over them for this case. Exophthalmometry is your best friend. If you don't have one in your clinic, you should get one in your clinic because it's incredibly affordable and it will save you from being sued. Also, it will help you save patients. And then digital globe palpation, you are just going to push on those eyeballs and see if one eyeball pushes back at you. And the reason that that one's important is because of this case that I had, not this patient, different case. She came in complaining of ptosis and double vision. I pushed on the eyelids and the left one pushed right back at me because there was a giant tumor in there. So digital palpation is very important. And then you want to look at the anterior segment. So if we're looking at the eyelids, you're going to shine a pupil at the eye and you're going to measure the distance between the pin light and the top lid, that's MRD1, and the pen light and the bottom, that's MRD2. So normally MRD2 is usually between 4 to 5 millimeters, and then technically MRD1 is between 4 to 5 millimeters. I would argue depending on the culture of the patient, can be 2 to 3 millimeters depending on the age as well. The big thing is they should be symmetric. Abnormal asymmetry is more than about 2 millimeters. Of course, dermatochalasis can always play a problem in that as well. And then you're looking at the eyelid margin as well, and just kind of looking at how are those eyes just resting. The next thing you want to do is see how the levator is functioning. And this is really important for checking for age. So you have them look down. Don't close their eyes, but look down, and you put your ruler up and put the 0 at the bottom of the eyelid. And then you just tell them, I want you to look up as hard as you can. And you want to see how much can that levator pull the eyelid up. So if it's levator dehiscence, meaning that over time, the tendon of the muscle that lifts my eyelid is a little loose or detached because I've been rubbing it for 65 years, they're going to have normal levator function. The muscle is just as strong as it's ever been. So they'll have ptosis, but they can lift all the way up. Versus if they have a third nerve palsy, they won't be able to lift that eye. As you can see here, I did it on myself. I have miraculous 14 millimeters of levator function. I'm totally fine. But it's something that it's a simple test, and you can do it on both eyes to check how good is the levator on both sides. So
Can you
for
go
this,
back one slide? Can you go back one
yeah,
slide? I
this
just
one?
want to, just cause again, we get the comments in the surveys all about the acronyms. So MRD1, MRD2, that's marginal reflex distance. So as you can see, the light is being shined there, and you can see the light and it's going up to the lid margin. So the marginal reflex, you'll see in the reflex, the margin, and the distance. So
Perfect.
that's it.
And then great, because that'll work out well for this one then. So when we look at our patient, the palpebral aperture size, which is the PAS, is 11 millimeters in his right eye, but 3 millimeters in his left eye. The MRD1, so the distance to the top eyelid, is 5 millimeters in the right eye. Literally, I cannot see it in the left eye. He's got an MRD2 of about 3 millimeters in that left eye. So pretty much that eyelid is almost on the floor. His levator function is 2 to 3 millimeters in the left eye, but his levator function is only 5 to 7 millimeters in the right eye as well. So even though he has a drastic ptosis on the left side and the MRD1 and MRD2 look normal, he has some levator dysfunction issues in the right eye as well. I did do exophthalmometry. I see no signs of proptosis. I did digital globe palpation and looked at the front of the eye, and those look normal. So the nice thing is that just based on that alone, I can now rule out that it's not aponeurotic, it's not Horner's syndrome, because with Horner's syndrome, you'll get a ptosis, but it's only like 1 or 2 millimeters. It's not like all the way to the floor. And I know that it's not a pseudoptosis because he doesn't have contralateral eyelid retraction. So now I'm only looking at, of this patient, what he could have, possibly muscular dystrophy, cranial nerve 3 palsy, myasthenia gravis, or MS. So now I get my cover paddle. So I'm doing my cover paddle. He has a very large angle exotropia. It's a basic type. So he's got a 35 prism diopter left XT. I do have to raise that eyelid to do his cover test because he's got a pretty good one. So based off of this, he still could have all of these diagnoses. So what is the next thing that you would want to check? So for me, ptosis and an eye movement abnormality, I'm thinking emergency. So the next one I'm going to check is pupils. When we're worried about third nerve, we're worried about the pupils. So the rule of the third nerve is if you have a complete third nerve palsy and the pupils are perfect, it's likely ischemic. If the pupils are involved, it's likely compressive. So what does compressive mean? So think in neuroanatomy, if something is pushing on the cranial nerve, so the pupil fibers aren't inside of cranial nerve 3, they run alongside it. So if there's something pushing, they'll push on both the pupil fibers and the cranial nerve 3. If someone's just having, vascular issues and not getting enough blood perfusion to cranial nerve 3, the pupil fibers will be spared. So that's what that means. So if somebody has an incomplete third nerve and they're pupil sparing, does that mean that they're fine? No. The problem is if they have an incomplete third nerve, about 14% of people with aneurysms with incomplete third nerves present to your office before the aneurysm grew enough to really push on those pupil fibers. And so if they have an incomplete third nerve, you have to essentially assume that it's an aneurysm until proven otherwise, even if your pupils are perfect. If it's pupil involving, it's compressive. Now, it might not be an aneurysm. It could be one of these other wonderful things that could push on it. But either way, you're going to want to do a workup. Now, depending on where you're getting compression on the third nerve, you can also have a bunch of other symptoms, right? So you can have hemisensory hearing loss. You can have hemiparesis or tingling or numbness in the arms and legs. You can have a stiff neck or a severe headache, right? That's why I asked about neck pain and head pain. Other cranial nerves, you can get technically a Horner's as well. And then proptosis, chemosis, which we already ruled out, and you're looking at the optic nerves. So when we have a third nerve, even if the pupils look okay, you want to look for an aneurysm. And so how do you do that? So why do we do that? So for aneurysms, it's one of those things where not all cranial nerve 3 palsies are aneurysms, but a high number of aneurysms present with a cranial nerve 3 palsy. And the reason is because of aneurysms. So aneurysms are just a weakening of a blood vessel that essentially grows, and our biggest worry is that it's going to rupture. So when you have an aneurysm, the most common place for aneurysms to be located is the posterior communicating artery, which is this guy. And guess what? Cranial nerve 3 is right next to it. So if that guy is going to have an outpouching, it's very likely to push on cranial nerve 3, which is why we always kind of want to say, if you think it's a third nerve, make sure you work it up. Risk factors for third nerve or aneurysm rupture would be increased age, female gender, smoking, high blood pressure, heavy alcohol, family history of an aneurysm, how big it is. So if it's bigger than 10 millimeters, and then if they have any genetic disorders. Aneurysms usually located at the posterior communicating artery and or the basilar tip have a higher risk of rupturing 5 years later. So those are the reasons that we get concerned and why we send these people to the ER. Oftentimes, if it's an aneurysm causing a third nerve, it's painful because the aneurysm is growing and it causes pressure, and there's not a lot of places for there to be things growing in the skull. So pressure will cause pain. It's usually not a fully blown pupil, it's a mid-dilated pupil, and it just doesn't really react to light. And the ptosis, while this patient was on the floor, doesn't always have to look like it's on the floor. So what are you going to order? Now, technically, if you look up the textbook, they're going to say the gold standard for an aneurysm is a digital subtraction angiography, but there's a morbidity risk when you do that test. So more often you're going to get an MRA or a CTA. It can detect the majority of aneurysms. If it misses an aneurysm, it's usually because it's too small, but the smaller ones aren't really the ones we're worried about rupturing, which is why people are usually okay with MRA or the CTA. Now, if they have a third nerve and they don't have an aneurysm, MRI, CT, lumbar puncture, and do know that giant cell can sometimes present with a third nerve. So if they're over the age of 55, you also want to add in some giant cell testing. Now, let's say somebody has an aneurysm and you saved their life and sent them to the ER and they had neurosurgery who clipped it or coiled it or did whatever they did to it. Of people who survive their aneurysms, usually the thing that resolves first is their ptosis. So do let the patients know that as their ptosis resolves, they might notice their double vision more, and it might take longer for the double vision to get better. Do not patch them. They just had a coil done. Patching is known to increase fall risk, as are progressives. So for these patients, what I usually put them in is a pair of single vision distance glasses, and then I put Fresnel prism on top until they have been stable for 3 to 6 months, and then I'll grind the prism in. But do be careful with these patients. They are a high fall risk. And if they fall, they can still have an aneurysm or a rupture of what was coiled. So Fresnel is super awesome. And then just recognize that they can be slow to grow and slow to change. So just keep a heads up for that. All right. So
Actually, Jack, before you go on,
yeah.
Natalie asked, how can we be so sure that it is a complete third?
Yeah, you can't. And that's why for me, I don't know your opinion, but for me, is it 25 prism diopters? Is it 40? I don't know. How big is it? It depends on the orbit. So for me, I personally just feel a new onset third nerve palsy, I'm going to work it up.
Of course. I mean, I think anybody who deals with this on a regular basis will agree that they should get imaged, including CT, CTA, MR, MRA. And your threat of aneurysm really depends, well, how you do it depends on what you think the threat of the aneurysm is. But if they've got a complete ptosis, they cannot raise or lid, you have to lift it, and they cannot adduct, elevate, or depress to any degree, I'm going to call that complete at that point, or as complete as you're going to get.
Yeah. I mean, could this guy lift his eyelid a little bit? Yeah, he had 3 millimeters, right? So this guy's making me nervous, right? And so, but his pupils are normal. So if the pupil's blown, it is the fastest get out of my chair, go to the ER you'll ever see. If the pupil's not blown, I have a little bit more time to do some testing. So for this guy, pupils are normal, color vision's normal, visual fields are normal, ocular health is normal. So I'm going to take the time to look at his eyelids a little bit more now. So the first thing I'm going to do is the fatigue test. So I just have him look up for about 2 minutes. And then I have him look straight ahead and see if I can make the ptosis worse. It is annoying to have people look up for a long period of time, so do let them know it's annoying to look up that long, but they can't look up and then look back down. They have to hold it for 2 minutes. The next thing I'm going to look for is a Cogan's lid twitch. So the Cogan's lid twitch is essentially a fatigable response of the eyelid, or called an irritable eyelid, that often commonly happens in patients with myasthenia gravis. It's rarely seen in a third nerve. But it's due to easy fatigability. So the way that I do it, it's taught differently depending on where you learned it, but I have found it most effective to essentially just do vertical saccades. So I have them look down, look up, look down, look up, and just go back and forth and kind of fatigue them that way. I have a video of one so you can see what it looks like, because it's very subtle. So what you'll notice, it's very prominent if you look in her right eye, is that it goes up and it comes back down. It goes up and it comes back down. She does have it in both. But this is what a Cogan's lid twitch looks like. And if you're not sure if you saw it on your patient, just keep doing it, because it'll keep coming around, because it's aberrant, or it gets worse with fatigue. So some people will say that you just have them look in sustained down gaze for a while and then look up, and to see if you can elicit it more. But I find that fast vertical saccades usually will fatigue them faster, and then I'll see it more.
Can you play the video one more time for the attendees now?
Yes, now that you can see it. Those are just the targets I'm having her look at.
Yep. Good, thanks.
Yeah. So the other thing that I like to do with eyelids is look at Hering's law of equal innervation. So technically they should be a little yoked to each other. So if somebody comes in with a ptosis, and they're, because of Hering's law of equal innervation, if I elevate a ptotic eyelid and the previous eyelid side gets a ptosis, or vice versa, an enhanced ptosis, this happens a lot in, it's called curtaining, and enhanced ptosis, it happens a lot in myasthenia. And so I elevate the better eyelid and I increase the manifest ptosis. So there's some things that you can do to kind of play with the eyelid to see if they're innervated appropriately. And then my favorite thing of all things is ice. So you do all these things to create ptosis. I fatigued her, I did the Cogan's test, and then I put an ice pack on there. And I put the ice pack on for 2 minutes and I see if the ptosis improves. So I measure it first, ice pack, and then see. A positive ice pack test is if you get 2 millimeters or greater improvement in ptosis. So for this patient, when I put on ice pack, he had a giant, right, ptosis. I put an ice pack on, and within 2 minutes, I opened it up and his ptosis was gone. So this patient doesn't have a third nerve palsy. He has myasthenia gravis. So myasthenia gravis is actually very common, and it's getting more prevalent over time, especially because it is kind of a condition that has a trigger. Oftentimes it's an infectious trigger, and we've had a lot of people that have kind of seroconverted after being triggered by COVID. So we've seen an increase in the rise of incidence and prevalence of myasthenia. It can happen at any age. So there's juvenile myasthenia gravis, and then you can also have early onset, which is when an adult gets it under the age of 50, or late onset when they get it over the age of 60. We do know that there tends to be a kind of a gender difference. Most of the time, early onset tends to be more females and late onset tends to be more males. So to remind everyone about how myasthenia gravis works, we know that we have a striated muscle that has end plate, or has receptors on its end plate. And so acetylcholine binds to the acetylcholine receptor and it causes muscle contraction. In order for that acetylcholine receptor to work really well, agrin has to bind to a complex of LRP4 and MuSK. And that's important for when we do lab testing. So MuSK is muscle-specific kinase and LRP4 is low-density lipoprotein receptor-related protein 4. So all you really need to know is that these are the other receptors that are needed for the acetylcholine receptor to function properly. And so if you have autoantibodies to any of those, you're going to have trouble with contraction. So what happens in myasthenia is that some pathogen causes an inflammatory trigger in somebody who kind of is predisposed to this condition. It causes chronic inflammation of their thymus, which causes autosensitization to one of those receptors or multiple. They get autoreactive T cells that create autoreactive B cells and then autoantibodies. The reason this is important is because the thymus regulates T cell reactivity, but we also know that 30% of patients who have a tumor of their thymus end up developing myasthenia gravis, and that a lot of patients with myasthenia gravis also have thymic hyperplasia or thymoma. And usually people who have later onset myasthenia gravis have a thymoma. So you do want to make sure and always ask, have you had a scan of your chest to make sure that they didn't have a tumor? Usually if they had a comprehensive neuro workup, the neurologist will order those tests, but Sometimes I've been surprised where a primary care physician thinks they can treat myasthenia gravis and they forget to order that testing. We're not quite sure what the role is of the muscarinic receptors, but we do know that there is a role in some patients' forms of myasthenia gravis. So essentially we get these autoantibodies. The autoantibodies bind to these receptors, which means that the acetylcholine cannot bind, in which case you get this fatigable muscular junction dysfunction. And you get fatigable weakness of our voluntary skeletal muscles. So why that is so important, and I can't emphasize this enough, is pupils are not skeletal muscle. Pupils are smooth muscle. So by definition, myasthenia can often present in funny ways, but the pupils will always be normal. So if somebody has a pupil problem, it is not myasthenia gravis. The pupils are normal, it could be myasthenia gravis. But you can get any type of double vision, EOM problem, ptosis, and it can be variable. Now, 15% of myasthenia gravis patients will have ocular myasthenia gravis only, meaning they only ever have problems with their eye muscles. They never end up getting systemic disease. But the majority of patients just present with ocular manifestations first, and they end up having generalization of myasthenia within usually about 2 years. So what happens when we have myasthenia gravis? We get skeletal muscle fatigue. We have facial muscles, right? That can also, so my face can get tired, but they also have proximal limb muscles that get tired. So they have a hard time getting out of bed. And then their muscles for swallowing and breathing, which is really where we get concerned. If your muscles of respiration get tired, you will asphyxiate and die. So that's why myasthenia gravis can be an emergency. A lot of times patients with myasthenia gravis also have thyroid disorders. So you do want to make sure they have thyroid testing and then thymus problems as well. So for our patient, just so you know, the ice pack test, his ptosis improved. Then just because I'm not, anytime it's a third nerve, I get nervous. So then I made him do up-gaze again. It got worse. And then I did ice pack again and it got better. So I just confirmed to myself, yep, this one's myasthenia. He had Kogan's lid twitch. So I diagnosed him with ocular myasthenia gravis. I did refer him to neurology. And of course, we all know that that can be a 6-month referral. So the big thing with these patients, and we'll go into why in a second, but you always want to ask them, do they have any trouble with chewing, swallowing their food, or breathing? Because if they do, that is a stat referral to neurology. And I always tell them, while you're waiting for your referral to neurology, if you have trouble with chewing, breathing, or swallowing, you need to call them and get seen emergently. If they don't have those symptoms, they can wait the few months sometimes to get into neurology. But neurology is pretty good for myasthenia, getting them in soon. I don't like my patients with big double vision that they can't control to drive. So I do say no driving if you have intermittent double vision you can't control. And I can't really give him prism at this point because he's very variable and it's not indicated because he's got a ptosis. So we'll pause for a second to do your other poll.
Okay, let me get that open.
And you're caught up on the questions.
So let me throw this out, and this could go to Jackie and Joe because you guys are more the experts in this arena. But when I look at third, sixth, and fourth, and I put them in that order, and the reason is that thirds come in, I don't know, it's like ivory soap. 99% of the time, they're probably getting image unless I know that they're vasculopathic because we're concerned. And then fourth is down at the end because I don't know the last time I imaged the fourth, but have I imaged the fourth? Yes. And then 6 is in between. Does that seem when this whole imaging people, and maybe that's why I jumped to, I want to know if it's a third because I don't have the comfort level, or ptosis versus, double vision. I'm like, okay, is this a third? Because I'm probably going to be referring it for an image. Do you guys kind of feel that 3, 6, and 4 are the kind of the order of imaging?
Well, it kind of, I think it depends. People who deal with this regularly will probably all agree that third nerves will get some sort of imaging. How urgent it is depends on the clinical presentation. Most neuro-ophthalmologists don't even agree about imaging 6. Some say you can watch it. Others say that you should neuro-image them right away. The reality is there is no aneurysmal issue that's going to kill them if you're wrong about it being an ischemic vascular 6th nerve palsy. And I've always said, and I teach my residents, if they have a 6th nerve palsy that's going to kill them, it's going to kill them now, it's going to kill them later. There's, there may not be anything that you can get involved in now. The fourth I can think of that I did image was not just a simple fourth, it was a complicated fourth. It was a patient who had a new onset small deviation fourth nerve palsy. And then he said, he mentioned, doc, my gripper's off. Like I don't, okay, so now we got hemiparesis there. His history, he was in quote unquote remission, but on maintenance chemotherapy for lung cancer.
Yeah. If you had
So,
cancer before,
yeah.
you're winning imaging again.
Yep. So
Yeah.
he is a person with a fourth that I imaged because it's complicated and a history of cancer. I saw him on a Thursday. By Monday, he was in hospice from multiple brain metastases.
Yeah. I've had a couple of six go the wrong way. I've had, and it's one of those of like, so for me, I will always run lab work, even if I think it's an ischemic fourth. So lab work for me is easy. And it's oftentimes you end up finding out that, their blood sugar is not as controlled as they thought it was anyways. But so the lab work for me is always an easy one. The question to image, because cost is always an issue. Depends on the case history. So for me, if they're saying yes to any of those questions, I've got numbness, I've got tingling, yep, you're getting imaging.
Mhm.
If they're very young, if they're not vascular. So for me, the whole thing of not imaging is because you think either it's vascular, meaning ischemic, or you think that they were born with it. And that's the beauty is everyone right now has selfies. And so if I'm not seeing a consistent head tilt, although I would say I have a lot of people who have a congenital fourth that don't have a head tilt. But it's the other big thing for me on a fourth, if you're thinking it's congenital, is they'll have ridiculous vertical ranges. So it's like, a normal person can only have vertical vergences more or less of 2 to 3 prism diopters in each direction. My fourth nerves can do like 10 to 15. And so if they were born with it. And so that's another one where I'll do vertical vergences if I'm wondering if I should image a fourth. Six nerves, I've had a bunch that are vascular, but I've had a bunch that were a bleeding disorder or some other weird thing. So I definitely still work them up. I think fourth is the only one I'm a little bit more kind of, I'll watch and wait a little bit more on that one. But I agree. I had someone similar tell me the same thing of like, if they've had it for a few weeks and it was going to kill them, they would have been dead by now. For a lot of the neuro-ophthalmologic emergencies, which is like a terrible, terrible truth. So onset matters.
Yeah, I've always had the approach that however long they've had is how long you got to work them up.
I was like, called today.
Yeah,
Okay,
and
so
the sixth. I'm
your
sorry,
polling question. Go ahead, Joe.
On the sixth, it isn't like you might be missing an aneurysm with a third, which can kill them. You're not missing that aneurysm with a sixth. There's no fatal aneurysm there, and they're said if it's something that's fatal, it's going to kill them now, going to kill them later.
I guess, you go back just to summarize kind of your urgent, I mean, like you said, it's going to kill them now, kill them later. But to me, the third nerve, if they're in there, they're probably, it's like after you do a little history that you did a beautiful job covering, the likelihood of them being imaged, if they have pain, pupil not involved, it's probably the third. The third is the one I'm kind of like, it's probably going to be imaged at some point.
Mhm.
And then your kind of fourth and sixth are based upon everything else. Not to say you're not going to image them, but if I laid them all out, probably my thirds. But maybe this goes back to Jackie's talk a little earlier. Maybe we should be imaging more. It gets more negatives out there. I don't know.
I think third needs to be worked up for sure.
Sure. Yep.
Six, I'm more likely than not going to work it up. Fourth, we'll see.
Right.
But again, I think that's just because fourth is the one that also most commonly has a congenital etiology. So
just trying to give some clinical pearls out there that if you're, you're trying to get your anxiety down, if you don't see a lot of this, I have, the ability to phone Joe. I text Joe. I call Joe. Joe, I need you. So, but I've gotten a lot better of them over the years, and it's kind of like, okay, threes, I'm still calling Joe. Sixes and fours, I'm, maybe texting them a little bit later. So
As I always say, when patients see double up and down, it's rarely a cause to frown.
yeah. I always say if the eye is down and out, so are you. I don't want that in my chair.
that's right.
But all right, so we will.
Here's your polling question. Here are your results. Prostaglandin's 14%. Your winner is beta blocker.
Good.
2% 24% is carbonic anhydrase inhibitors. Your rho kinase is 6%, and your alpha agonist is 13. So your two winners are 40% beta blockers, carbonic anhydrase inhibitors at 27.
Okay. So good job to the beta blocker people. So when you have someone who has a diagnosis of myasthenia gravis, one thing to always remember is that beta blockers are contraindicated for them, including topicals. And the reason is because beta blockers have been one of the agents, including topicals, to cause or trigger myasthenic crisis. So while we don't normally think of myasthenia gravis as a neuro-ophthalmologic emergency, it actually is. Now, it used to happen more often before we had Mestinon or neostigmine, which is a drug, right, that we use to treat myasthenia gravis. We used to have a lot more myasthenic crisis, up to 75% mortality. It's gone down to less than 5% in recent years, but we do know that people, even though it's less likely that you're going to die, about 20 to 30% of people will have myasthenic crisis within their lifetime, and it's often triggered by something. Stress, pregnancy, a beta blocker that a optometrist didn't know they weren't supposed to prescribe for their glaucoma. So I always say if somebody has myasthenia gravis and you see it in their chart, just put somewhere in the chart contraindicated for topical beta blockers. And I've had so many times where I've had a patient post-op from a cataract surgeon and they're my patient and they had an IOP spike. And then I send them, right, and I'm like, and I see that their ophthalmologist put them on beta blockers for the IOP spike. That's awesome, but that patient is myasthenia gravis, and I will send a friendly note to the ophthalmologist that I would recommend that we change that to something else. And oftentimes ophthalmologists are like, oh, right, I forgot about that. So people just forget that they're contraindicated. Think of kind of like breathing problems, asthma. Don't do myasthenia either. These patients do require ventilator assistance. We had a lot of issues with this during the pandemic when ventilators were low. So how do you
So a
diagnose?
lot of people, just to kind of give a clinical pearl, a lot of people are like, oh, I don't use timolol when they spike, but you might use Combigin, you might use Cosab, and they have beta blockers in them.
I know. I mean, I like beta blockers.
Oh, I do too. So
yeah. So, other kind of pearls about how we're going to diagnose it. So at the end of the day, myasthenia gravis is often diagnosed with clinical testing that I went over already. So even though we were all taught the Tensilon test, the Tensilon test has a very high likelihood of having bradycardia or arrhythmia or hypotension that could kill a person. So oftentimes they're not doing that anymore. And so usually you're going to send for serologic testing for autoantibodies and thyroid disease, and then a CT or MRI of the thorax. And then oftentimes I find my neurologists are more likely to do a neurophysiological specific test. So putting a probe into a nerve to see, or a muscle to see how it twitches, which is incredibly painful for the patient, before they're going to put them on the Tensilon test. And oftentimes I have neurologists that are like, oh, let's just start them on neostigmine and see if they get better, because that is more benign than the Tensilon test. But I think what's cool about the paper that I put on here is that studies have actually shown that when a patient has a ptosis, of all of the tests that you could run someone for, the ICE test is more sensitive and more specific than lab work, Tensilon tests, like you name it. And that's kind of cool because it's so easy to do. So don't forget about the ICE pack test. It's one of the best ones for myasthenic ptosis. Now, this study said that it found that it was also sensitive and specific for double vision. In my opinion, I've diagnosed many people with myasthenia. I don't often find their double vision gets better with the ICE pack. But you know, that was contra to what this study found. But in my experience, the double vision doesn't get better. The ptosis does, though. So once I think they have myasthenia gravis, send for lab work. What I send for, I put at the bottom. So these are the lab work kind of that you're going to do. So acetylcholine receptor binding antibodies, blocking antibodies, modulating antibodies. And then you want to look for anti-muscarinic or anti-LRP4 autoantibodies as well. Not every patient who has myasthenia gravis will have positive lab work. So sometimes they have myasthenia, but their lab work all comes back negative, and it's called seronegative myasthenia. And these are the patients that if you do a trial of neostigmine on, they do well. And then the other thing that I always remind people of is think about how we treat. So oftentimes they're going to be put on pyridostigmine, neostigmine, depends on kind of where you are, but it doesn't always immediately help the double vision or the ptosis. So oftentimes in the immediate onset, they're going to put them on steroids. Steroids are going to be the best thing to take down the double vision and the ptosis. But do know that with steroids comes a lot of side effects. And so I always have these, it's never a punt. I always have these patients come back to me in 4 to 6 weeks. I've had a couple of steroid responders that didn't know they were steroid responders. And with myasthenia gravis, oftentimes these patients sometimes are chronically on and off steroids, because steroids does a really good job of managing the symptoms, especially if they're just not stable. So for this guy, 3 months, he comes back, he's been on methadone and oral steroids, ptosis is gone, exotropia is gone. There's nothing like see a 35% after XT gone. But these drugs do wonders. So, but the key is just knowing how to do the workup, how to know not to send that one to the ER and to send this one to the neuro. So any questions on that one at all?
What I've had success with is that, I live in the rural part of Pennsylvania, so sometimes I'll order some different meats and things that come in, and they come in these old gel packs and so on and so forth. So that you could use ice, if you have a staff lounge, go get some ice, put it in a bag and use it. There's your ice pack test. But what I found is I got this gel thing. It said colder than ice. You could throw it in the refrigerator. I don't know, our refrigerator works at 38 degrees Fahrenheit. And I throw it in there, and it's cut, instead of being 32 degrees, I guess, of ice, it's a little bit jellier. It can kind of get in there. I guess super cool those enzymes is what we're doing. And just seem to just wrap it in a paper towel. And, this was from one of my products that I ordered. So when people are looking for the ice bag for that clinical, like this little gel, you can get those ones that you crush and turns cold immediately for like when kids hurt themselves or adults hurt themselves. I just have one that's kind of reusable. I keep it in the fridge and grab it whenever I think I need it.
Yeah. Yeah, and that's a
So.
good point of why the ice works. So what it does essentially is it slows down the enzymes of acetylcholinesterase so that it allows acetylcholine to be in the synapse longer. So it's more likely to bind to any of the receptors that are still open, which is why if you're not breaking down the acetylcholine, they're more likely to have a contraction of the muscle. One of the other reasons too why eyelids, of all the muscles in the body, why the eyelids are most likely to present as your first symptom of myasthenia gravis is because you actually have the least number of acetylcholine receptors in that muscle tissue compared to the rest of the body. And so if you're going to have anything binding those acetylcholine receptors, you're going to have more likely to have issues in the eyelid than anywhere else.
And another way to inhibit, we're inhibiting an enzyme so that the acetylcholine can work. And there are two ways to do it. One is to supercool the enzyme, and that's why I use ice pack. But if you heat an enzyme, it can also inhibit it, and that's why a heat mask can also be used. Now, I've not had the occasion to do that, but there are reports that a heat mask will work as well.
Yeah, you have to really heat that thing up. Interesting. I haven't heard that. I've had some patients where the ice pack will last for like 20 or 30 minutes, and it's scary, but a lot of them are like, I just put that ice pack on right before I'm about to drive, and then I can get home before that thing comes back down. And I'm like, that's terrifying, but I'm glad you figured out a way to get home safely. So, but the people will use the ice pack even just for their symptoms throughout the day. Okay, so we'll go from double vision. We'll take a small break and we'll talk about vision loss. So let's say that the patient calls or they're in your office and they're like, I just lost my vision. So the first thing that I do is I check their vision. Let's say it's 2400. The next thing I do is a pinhole. I want to know if it's getting better. If it drops really quickly, I'm going to refract and take a look at the slit lamp, right? So if the 2400 to 2020, we're just going to go for refraction. But let's say it doesn't get better, right? Well, the next thing I want to check is pupils. So do I see an APD? If I see a relative afferent pupillary defect, I'm going to dilate them and do an OCT, because that means that there's something wrong with that eye that is before the optic chiasm. And that's what I'm looking for. If they don't have an APD, it doesn't mean they're great. It means now I need to run fields. And it's important because I think a lot of people dilate quickly, but visual fields are very important in acute vision loss. So if they have a unilateral defect, I always feel like Oprah when I do this slide, they went and dilated fundus exam and an OCT. And if they have a bilateral defect, they went and dilated fundus exam and an OCT. So the key here is just know you need to do your fields to get a better visual field, you need to do your visual fields ideally before you dilate them, because people have garbage fields after dilation. Oftentimes for a neuro defect, you might still find it like a hemi or a quad, but some of the scotomas can be a little messed up after dilation. And then a lot of them are going to get an MRI. So really the big thing for us is if you have acute vision loss, all of a sudden you don't see, that is a sign that you could be having an emergency. But also transient vision loss, right? So when we think transient vision loss, my vision dimmed to gray and then it came back, we always think Amaurosis fugax, we're worried about a vascular occlusion, particularly of the carotid artery or along its distribution or an emboli. Do know that you can get transient vision loss with migraine. So migraine aura can also present with that, and you can have an acephalgic migraine, which is essentially you get an aura without the actual headache component, which is different than technically a retinal migraine, which is when you're actually getting a vascular contraction within the retina, giving you that atypical aura. You can also get transient vision loss from giant cell arteritis. So it's not your only differential when you have transient vision loss. So with giant cell arteritis, oftentimes, and this is the big one for us, obviously we're worried about stroke with amaurosis, but we're also worried about GCA, which can also cause stroke. So with GCA, it's a systemic vasculitis affecting adults over the age of 50. It's rare in people under the age of 50. Now, most textbooks will say things like, don't worry about it unless they're above 60. But there are some cases, 2% of people that are 50 to 60 years old. So the rules of thumb I always had is if they're over the age of 55, it's okay to just rule it out. Every decade after 50, the incidence increases pretty drastically. It's more common in women than men and more common in Caucasians or Nordic, Northern European ancestry or other northern latitudes. More often than not, it's going to present with arteritic anterior ischemic optic neuropathy, but you can also have it present with a central retinal artery occlusion, or they can also have ocular ischemic syndrome as well. So do know that when patients present with visual acuity 2200 or worse with ischemic optic neuropathy, usually you're more concerned about arteritic. That's what I've always been taught, but I always say in general, you just always want to rule out that it's not arteritic versus you never want to just assume. It's always better to run it. We're also usually just running lab work here most of the time in the beginning. Do know that oftentimes if someone's coming in with with vision loss after arteritic anterior ischemic optic neuropathy, it's likely not coming back. And what you're really trying to do is save vision in the other eye. So how does it happen? Similar to myasthenia. So some type of trigger, possibly an infection, causes this patient's immune system in a genetically predisposed person to essentially launch this T-cell mediated granulomatous inflammation of medium and large vessels. And I know that's a definition we've all memorized for boards, but I always like to think about that. When I think granulomatous, I think about mutton fat KP, right? So I think about really big inflammatory cells. And then I think medium and large vessels. Well, what are my important medium and large vessels? My aorta would be a large one I think is important, as long as along with my carotid arteries and my temporal arteries. So those are the big ones. And we know that the carotid artery also has this really important branch called the ophthalmic artery that we usually like to also have patent blood flow. And the problem is that when we have inflammation in vessels, we would wish that our vessels would expand outwards, but they don't. When they get inflamed, they collapse inwards. And so they end up narrowing the lumen. And so when you get persistent wall inflammation, not only do you get vascular damage, but you also get stenosis, which can lead to occlusions and then aneurysms over time. So it's an emergency for multiple reasons. Obviously, number one, blindness. So losing vision, neuro-ophthalmologic emergency. Also, though, if you have any type of issue in the other distributions, you can have a stroke or an aortic aneurysm. So the sooner that giant cell is diagnosed and treated, the lower the incidence of vision loss and also the lower incidence of stroke and death. But the main goal of treatment is to prevent vision loss in the fellow eye, which usually happens within a few days of losing vision in one eye. Now, the symptoms, I know we've all been taught are, I have jaw pain when I chew and things like that. And we're always taught for arteritic anterior ischemic optic neuropathy to look for sudden vision loss. But like I said, if somebody is having a stenosis or occlusive event, it could be temporary. And so before they have the sudden vision loss, they might actually be having transient vision loss. And so a lot of these patients 30% can often present with transient vision loss. So when you're going for the carotid Doppler, don't forget to also run lab work. The big one for me is double vision. And this, Greg, kind of goes to previously where I have maybe 5 or 6 cases of giant cell I've diagnosed off of a isolated cranial nerve 6 palsy alone. And so for me, cranial nerve 6 is one that I get nervous about because I've had some giant cell cases with it. And then eye pain. And the nerves aren't always involved. So I have had cranial nerve 6, nerve looks fine. I just have GCA as part of my normal workup, and then it ends up flagging. We always think of jaw pain, neck pain, and headache. Patients I've had who've had this, it's the worst headache you've ever had in your entire life. And then scalp tenderness as well. But some patients actually, their symptoms are actually unintended weight loss, not feeling like they want to eat, muscle pain, and malaise. And that's why I have those in my initial intake, because a lot of patients, we think, oh, they don't have jaw pain, they don't have temporal artery tenderness, they're probably fine. 20% of cases with permanent vision loss from giant cell presented without systemic symptoms of giant cell arteritis. So for me, if they, smell like they could possibly have giant cell because it's such an immediate or urgent emergency, it's always okay to order blood work. I've never had someone be like, man, I'm so mad you ordered a blood test that came back normal. The MRI, sure, it's expensive, but giant cell, I've never had anyone mad about it. If you do blood work, what are you running? So you're going to do an elevated ESR or erythrocyte sedimentation rate. Now that is not specific to giant cell. It is just a general marker of having inflammation in your body, as is CRP. So C-reactive protein. It can be, normal in patients with GCL a couple of times too. But also know that in general, both of these are non-specific markers of having inflammation. So someone could also have an active infection like the flu or cancer, and that might be elevated as well. And then oftentimes they'll also have an abnormal CBC with differential, because they also can have some other issues with their platelets. But so you essentially run for blood work stat. If the blood work comes back positive, oftentimes, at least how I've done it, and you guys can say if you've done it differently, but for me, we start them on oral steroids and then we refer them for a TAB, which is a temporal artery biopsy. You usually want to do it on the side of the palsy or the side of the optic nerve, optic neuropathy. But do know that not everyone has a positive temporal artery biopsy on the first time. Sometimes they don't take out the right segment. Sometimes they have to do it again. And so they need it sequentially, but oftentimes you can start the patient on treatment if you think that they have it so that they don't have a stroke while they're waiting for this test. And then they have usually up to 14 days before that could really impact their temporal artery biopsy measurements. So I don't know if you guys do differently as far as managing yours.
Well, typically what I've been doing are now ultrasounds, easy to get. I've got a vascular surgeon will do it same day or next day if I reach out, so that's pretty easy. And because this is a lifelong disease and they're going to have flare-ups, if we take their arteries away, we can't really do it again. So if it flares, we don't have any sort of diagnostic test.
Yeah, mine's pretty easy as long as they haven't had a central retinal artery occlusion and they're going to the stroke ER, so on and so forth. If I'm leaning that way, I have a rheumatology practice. It's a 7 to 8, depends on the docs, man, woman rheumatology practice with one of the docs in there that did a special eye rotation. So I'm like, okay, this is what I'm thinking. I'm sending them over to you after I maybe do some initial blood work. I'm sending them over to you because they're the best to really work with the steroids. So it's really lucky once I kind of do the initial blood work and lean on it, and I'm like, okay, you're going over here. So
Now, while the poll is going on, a couple of questions came in, and one is coming from Matthews. Really good question. Is palpation on temporal artery having a good pulse good enough to rule out GCA? Jackie, what's your thought on that?
No.
I agree, but it's nice. It's helpful. I will.
Sure.
I will do that, and I will put that in the record because this is a variable presentation. And remember, this is a clinical diagnosis. Everybody, the tests help direct us, but ultimately it comes down to what you clinically think that it is.
Yeah.
And a real quick one. This was a few minutes ago. Can you explain retinal migraine, ocular migraine, and acephalic migraine?
Yes. So according to the International Headache Classification, there is a very big difference between retinal migraine, ocular migraine, and acephalgic migraine. So technically, and this has kind of always been fascinating to me because I was always told that they were synonymous. But a retinal migraine, by definition, is actually that you have a vasospasm within the retina, and that there are some patients where they've even had a patient in the moment of having one, and you can actually see a vasospasm within the retina. And that can be an ominous case for if they have a vascular occlusion in the retina. So you do want to work those up if they have a retinal migraine. And essentially it's like vision loss, right? And again, you're doing the OCT, you're making sure that they don't have an occlusion, you're dilating them. An ocular migraine, I think, is oftentimes when somebody has an acephalgic migraine, which is where a patient essentially has a migraine aura that is not followed by a headache. And so we used to call them ocular migraines, but because people got ocular and retinal mixed up, I think they've switched now vernacularly to an acephalgic migraine, meaning an unpainful migraine. There, you don't get the painful headache. Or you could just say migraine aura, right? At the end of the day, you're just diagnosing the migraine aura. By definition, and I always say this is important because when patients come in with transient ischemic loss of vision, a migraine aura usually lasts for about 20 minutes up to 60 minutes. So if somebody's coming in with transient ischemic loss, it's going away for a couple of seconds and coming back. That's more of an issue with perfusion or an occlusion or an emboli. If it's there for 20 to 60 minutes, it's pretty much a migraine. And migraine auras can be terrifying. Like, we have a lot of migraine patients in our group, and it's like, they'll tell you like their whole vision collapses. The other thing is it's bilateral, right? Usually with a migraine. Now, the positive phenomenon, like the scintillating scotoma, can sometimes be unilateral on one side, but it's not coming from one eyeball. And so that's kind of the differences and the nuances with them. And I think that vernacular has changed recently with the newer headache classification of trying to differentiate the retinal migraine from acephalgic migraine aura.
So the visual aura, if you go and type visual aura into Google, the two words, I do it all the time for my patients, because there's a bunch of images there. I go to Google, I have two screens in my office, type visual aura, hit enter, hit images, and they all pop up. Remember, the visual aura, if it's at acephalic, or if they have it with a headache, cephalic, then that comes from the base of the skull, right? The cortical depression, whatever. It's kind of back here, creating that bilateral issue. I think of a retinal migraine, and geez, I can't even remember last time I even saw a retinal migraine, but it would be more, remember that the retinal vessels of the retina can auto-regulate. This is kind of how I think of it, might be right or wrong, but this is how I kind of keep it straight, is that the retinal blood vessels can auto-regulate. That's why your blood pressure reading is not the reading that's in your eye vessels, because they would just blow out. So to me, it's kind of like a spasm of the auto-regulation, creating this issue of this retinal migraine. I don't know. I see more visual auras all day long coming from the back of the skull than I do retina, but I'll let Jackie and Joe weigh in. It's pretty much visual auras all day long.
Mm-hmm.
Yeah, retinal migraines are actually very, very rare. They're commonly diagnosed inappropriately, but they're actually in actuality very rare.
Good. I'm glad you said it, because that's what I wanted to kind of lean on too. Everyone calls them retinal migraines, but it has nothing to do with the retina. It's back here at the base of the skull. So,
especially if it's colored, right? So color is processed in the occipital lobe. So if they're telling me I've got a colored spot, that's not coming from the retina. That's coming from a vascular condition. Like, I've had a couple who've had poor bleeding, like cardio patients, or it's coming somewhere within the brain. And it's just, again, you don't process color at the retina. So that, I always feel good when they tell me it's orange. It's orange in color. Oh, good.
and the bilateral part too. So yeah. All right. And you mentioned that earlier. I just wanted to echo it. So your answer to your polling question is 54% said polymalacia rheumatica. Then right down the line, atherosclerosis at 36%. And then 4% and 2% for your Theis, Jaci arteritis, or your migraine.
Okay. So when somebody's coming in with symptoms of giant cell arteritis, the common things that you're looking for, as we've discussed, migraine is common, atherosclerosis is common. But actually, one of the conditions that for me is a yellow flag to always be worried that someone might end up with giant cell is PMR, or polymyalgia rheumatica. So we know that 30 to 50% of patients with giant cell also have PMR, and that PMR is 2 to 3 times more common than giant cell arteritis. So that is something that you always want to take note of when you're taking your history, and just always rule that out. So very common. All right, so we talked about it before. So you're going to put them on steroids. Either you can put them on oral steroids, or you can have a friendly co-manager put them on steroids. Depends on how close you are with their management team. If it's really, really bad, or they're losing their vision or blind, you can have them go to check them into the ER to get an IV. Also an option as well. And then they're usually on the steroids for a very long time, if not their whole life. So as you mentioned, it is a periodic condition. And so they, as they get better, sometimes they'll wean them off the steroids, and then it comes back. So then they go back on the steroids. There's a lot of great drugs coming down the pipeline for autoimmune disorders, but I think, Greg, you nailed it on the head. Who are you sending these people to? And I always like to say that because I think people never know, right? You diagnose it, now what? Rheumatology. So rheumatology is going to be your best friend, but know that these patients are on chronic steroids. So one of the big roles for you is to see them in a few weeks. One is to check their vision. So we know that these patients, their vision isn't going to improve. Oftentimes the vision will get worse for the first few days, even on a steroid. And so you do want to just check for that, but then also know that these patients are a high stroke risk. And if they're going to be on steroids forever, then you're going to be looking for things like cataracts and glaucoma and things like that. I mentioned before, there's some other adjunct that immunosuppressants that you might see that they become put on. They're trying really hard to get these patients off steroids. The patients love the steroids, they feel great on them, but they also have a horrendous number of side effects. And then I mentioned it, but I would be remiss if we're going to talk about ocular emergencies if we don't talk about CRAO. So central retinal artery or branch retinal artery occlusions or ophthalmic artery occlusion is an ophthalmologic and life-threatening emergency, and it is pathophysiologically analogous to an ischemic stroke. So if you see someone that comes into your office and they have any type of artery occlusion, you are sending them to the ER, and not just any ER. You're going to send them to a stroke center. And so essentially when you have any type of embolic occlusion, even if you don't see the emboli, they're essentially shooting clots off from somewhere. And so they need to be worked up. And both the American Heart Association and the American Stroke Association considered retinal arterial ischemia to be the equivalent of cerebral ischemia. So this is what the standard stroke workup is. But if you send them to a stroke center, they will do the standard stroke workup. But this is what they're going to be looking for. And the reason this is so important is because a study has shown that the highest risk of having a stroke is the first 1 to 2 weeks after you've had an acute retinal ischemic event. And so you can save lives. And they essentially, this is the big thing for me, is I don't like to order tests if it's not going to change someone's management. And what they found is that of the patients, when they ended up sending them to a stroke center, the majority of them had critical carotid artery disease they didn't know about. They had a coincident acute stroke they didn't know about on the ipsilateral side, usually. Of the CRAO, a lot of them, their blood pressure was super high, so don't forget to take their blood pressure. And then a lot of them had some type of heart attack as well. And so of these patients that were sent to the ER, 93% of them ended up having a change in their medication management of their regular cardiovascular disease. That's huge. That means all of them needed something. 25% of them ended up needing urgent surgical intervention. So again, if you see these acutely, what are you going to do? You're going to check their blood pressure and immediately send them to a stroke center. Now, more often than not for these patients, usually we're not seeing them acutely. And I find that this is the other thing that goes unnoticed, is that we find these patients later, right? They have, because the retinal opacification usually goes away within 3 months. And so the optic nerve looks okay, and the fundus looks okay, but they'll have collateral vessels. So collateral vessels, you have to differentiate it from neovascularization. But if you see a patient who has collateral vessels, and I always ask, have you ever had an event where you suddenly lost your vision? And patients will remember these events. Oh yeah, this one time I woke up, I couldn't see for like 2 days. And then I'm like, did you ever get worked up for that? Right? And that can be the other thing too. You might not be sending them to an emergent stroke center, but you might want to say, patient has blood vessels on the disc, suspicious for collateral vessels, with a history of sudden vision loss that is consistent with a possible artery occlusion. I would recommend the patient go back to their primary care physician and have an embolic workup if they don't have current symptoms of stroke. Now, what are the current symptoms of stroke? And I'll do this and then kind of leave it for questions just based off time. But wait, am I right on time or am I?
We're really right about there. We need to land, and a question did come in.
Good. So we'll end on this one then, because this is what I think is the most important slide that I have, which is how to identify a stroke. So number one is the fast approach. Their face is drooping, their arms are weak, they have trouble with speech. It's time to call 911. But do know, obviously, vision problems, CRAL, things like that. All of these can be symptoms of stroke. Not every ER is a stroke center. And so this QR code is a link to the American Stroke Association, and you can put in your office address and your home address so that you can find what your local stroke center is near you so that you can create a plan. Because I've had patients in my office that they're having a stroke and I have to send them out and I know exactly where I'm sending them. And I always say the best plan is to have the plan. So I always would say, take the time, figure out where you need to send them, and know that stroke's going to happen everywhere. But if you have this QR code available and you happen to be on a soccer field or whatever, you'll be able to get someone where they need to go fast. And calling 911 is always helpful too. So.
And interestingly, I'm seeing more and more they're going to do the acronym B fast, with the B and E being balanced and I. Now, we got a couple of questions. For artery occlusion, we still spend time checking BP if management does not change if you're sending to a stroke center. And personally, I think it's good to check. It doesn't take very long.
Sometimes I've had patients, again, with that, I need to convince you to go to the ER. You'll have patients. I've had patients who like their blood pressure is literally like 210 over 180. And they're like, you just make me nervous. I'm like, I don't make you that nervous. And so I also have a form in my office of, I was told to go to the ER and I refused to go. And I make them sign it if they refuse to go. Again, sometimes giving them the data of like, your blood pressure is 210. You need to go to the ER. But some people still won't go. So, and that's the other thing too, from a med legal perspective. I always call the ER and let them know I'm sending someone over so they know to expect them. I tell the patient where to go. If they have confusion or they can't seem to get themselves there or they shouldn't, then we call 911, we have them come. And knowing who to call is always important, but you do need to document, right, and follow up and make sure they got to the ER.
I think the last question is, how do you manage and this is a whole topic, but
Hey, Joe, before you do that, I'm going to have you do that because I want to just show them that it is active, the survey, and they can go there and start doing that while we're doing question and answer. And now we're here at the question and answer slide. Thank you.
Yeah, how do you manage a Howland horse plaque in an asymptomatic patient? Would you send for a stroke up or do you not? Jackie, your approach to that? I know what my approach is.
Well, now I'm nervous about my approach. I mean, my approach is always, if I see an active Howland horse plaque and they're asymptomatic for having a current stroke, I don't know how long that thing has been there. And so usually I'm not going to send them to a stroke center to get an emergent workup, but I am going to send them to their primary care and I'm going to order a carotid Doppler to make sure that they're not shooting a clot there. And then possibly, I usually do that first. It's the easiest one to get. And then if those are completely patent, I might consider sending for cardiology to do, an echo and an EKG.
Yeah. For me, the asymptomatic Howland horse plaque that you come across, I'm going to send to the internist and ask him or her to do a general atherosclerotic evaluation. I was doing this lecture with an internist, and he said that if you send a patient to me as an optometrist and you ask me to do a carotid evaluation, 100% of the time I'm going to do it because you asked me to. And we don't always like what we find. And if I find something, I'm compelled to act. And as he went on to say, every internal medicine colleague he has at least one person in a wheelchair as a result of a carotid endarterectomy. So please don't tie my hands. Tell me, what you see and ask me to do an atherosclerotic evaluation, and I'll handle it as I think best. And that's how I would approach.
I think it depends who you work with. And that's the one thing I'll say for interdisciplinary management is find your people and ask them what you want them to ask, right? Because I've had the opposite where I've had people like, I love when you send referrals because you tell me exactly what to do. It's the easiest referral. I don't have to think. And then there's the excellent ones like the one that you have where they're like, I know what I would be doing if you said this problem and I would do the appropriate workup. And so I usually say, take the people you're referring to out to lunch. Make good connections with those people and then ask them what you want in a referral. I have found it's so different in different professions and even within the same profession, cardiology. Same thing with co-management. I'll often ask, hey, I know you referred this patient to me. Do you want me to send you a note every time I see him or just like once a year? You'd be surprised how many like doctors are like, I want a note every time you see my patient. I'm like, okay, that's a lot of notes, but okay. But it makes for great relationships. But I agree that too of like, That's kind of like when somebody sends me snow and they're like, please do comprehensive workup with MRI. And it's like, well, you had to say MRI. Like, I have to do the MRI. So I understand that completely.
Well, Jackie, I want to thank you for a great presentation, very solid information, a lot that our audience can take away. We are running on time, so I'm going to have Greg wrap this up and bring it on home. But I do want to thank you for your expertise and sharing it with our audience. So thanks so much.
Thank you.
I just want to take 30 seconds here to talk about this whole Holland horse pack asymptomatic, talking to Joe, talking to Jackie, talking to Valerie Boyce, talking to Andy, Lee. I think the summary is that they don't have to have go to the emergency room that day. They do need to be worked up, however you want to do it. Internist, stroke neurologist, just get them worked up, but it doesn't have to go to a stroke-ready hospital. But I find it interesting that if you have an artery occlusion, if you can see my hand here, and I have a business card, the reason you get an artery occlusion, a branch, is that you can't see the Holland horse plaque because it's too thin. And the reason why you can see a Holland horse plaque is because it's lodged in the artery this way. So I think it's just kind of funny that if it lodges one way, it's an emergency, but if it doesn't, but it goes back to what Jackie said earlier, is that you don't know how long it's there. So that's why you just need to get them worked up. All right. With that being said, Jackie, I'm going to echo what Joe said. Thank you very much for doing this tonight. I'm sure you didn't get through all your slides, so we can always do what we do for a lot of them, add a few more slides, and we'll do part 2.
Okay.
So thanks everyone for attending.